Hi everyone, Mike Siah. One disclosure, I'm a vascular surgeon. So I think everybody in the room is cognizant of the fact that we're facing an increasing burden of critical limb-threatening ischemia, and that's likely due to the fact that we're not controlling for diabetes as well as we could be. We're not treating kidney disease earlier, and in 2050, nearly 25 million Americans are going to be potentially having peripheral arterial disease. So everyone in this room sees some spectrum of this story, right? 67-year-old patient comes in, or you're referred to this patient, they've got coronary artery disease, obesity, diabetes, plus or minus heart failure, and they've got a non-healing wound. Now, this patient was seen by our foot and ankle surgeon, and the patient presented to our wound care clinic with this wound that developed following a Charcot reconstruction. In addition to the wound, the patient had fevers, chills, and was admitted to the hospital with a leukocytosis of 16,000. So x-rays were taken, empiric antibiotics were started, and the podiatrist was smart enough to get some arterial non-invasives, which demonstrated pressures that were not consistent with wound healing, a toe pressure of 29 millimeters mercury and a TBI of 0.1. So my podiatrist booked this patient for a combo case in our hybrid room, where she did a debridement and washout and scheduled me to do a left lower extremity arteriogram. So you can see here, this patient didn't have any aortoiliac disease, didn't have any femoral popliteal disease. And you had single vessel runoff via a robust perineal artery with a patent but heavily diseased anterior tibial artery. And going distally, we can see a very large perineal artery that provides reconstitution to the plantar arteries, as well as the distal anterior tibial artery, which has a focal high-grade stenosis right at the ankle. So right now, what do you do, right? So you've got the patient on the table, podiatrist is done with their debridement. As a surgeon, I've got a variety of options available to me. I can do a bypass, but probably not going to want to do a bypass in a patient who may or may not have conduit and who has a large dorsal foot wound, because I'm probably going to be sewing to that distal anterior tibial artery. And the risk of infection, potential surgical site complications, pretty high. Conventionally, historically, people have used conventional balloon angioplasty to take care of tibial disease. In fact, that's probably the primary therapy that we have available to us today in 2023. And the fundamental mechanism of POBA is the rupture of arterial internal elastic lamina. You're basically causing a dissection by dissecting plaque off the medial and adventitial interface. And we know that POBA, or conventional balloon angioplasty, is not the best thing that we can be doing for patients, right? We've known this for a long time, with not very durable results at 1 month, 6 months, and 1 year. And this was evidenced most recently in the BEST CLI study, which demonstrated that the endovascular therapy, and POBA was the most common endovascular therapy offered to these patients, had a higher rate of early reintervention. Now, these reinterventions and the failure of POBA are limited by the fact that POBA causes elastic recoil, it causes dissections, and over longer periods of time, we see neointimal proliferation. Now, the prevalence of recoil is something that I don't think people talk enough about. But Dr. Baumann and his group wrote this paper back in 2014, which looked at recoil following tibial angioplasty. Now, these patients got prolonged balloon angioplasty, 180 seconds. After this intervention, an angiogram was performed 15 minutes later, and they showed that 97% of patients had elastic recoil. And that resulted in a 29% lumen loss at 15 minutes. Now, we talked about this very early at this presentation about the increasing burden of diabetic disease, but the sad reality of the fact is recoil occurs more pronounced in diabetic patients. Now, beyond recoil, dissection. Now, below the knee, we don't have very many tools available to us for the treatment of dissection. Now, obviously, above the knee, we have all sorts of technologies, whether it's drug-eluting, drug-coated balloons or drug-eluting stents, but ultimately, these too have their own individual shortcomings. So innovation is obviously needed, right? Drug-eluting balloons are exciting, but they may not have been the answer. Drug-eluting stents, unfortunately, Saval was an unsuccessful trial, and the historical use of bare metal stents, like I said, all have their shortcomings. So we need to improve our outcomes, and potentially a new angioplastic mechanism is needed. So Serration Angioplasty has taken industrial technologies and applied them to the vascular space. So we're all familiar with serrations, whether we're using fancy scissors to cut construction paper, helping our kids do their home projects, whether we're using saws, or whether or not you're working on the farm, right? So the application of serration to angioplasty involves the placement of linear serrated strips along the length of a conventional angioplasty balloon. And these strips, in and of themselves, allow for the delivery of point force that's 1,000 times stronger compared to the force of conventional angioplasty balloons. The most important component of this, though, I think, is the low and slow inflation. Being able to deliver this much pressure at very, very low atmospheric pressure, thereby potentially mitigating the risks of recoil and dissection. So by using serration, you're going to optimize luminal gain, avoid dissection, which ultimately will minimize reintervention. And it allows for a more predictable result after conventional angioplasty. So if we go back to the case, after crossing from above, I advance an 014 IVUS. You can see down at the dorsalis pedis, we have a 3.9 millimeter blood vessel. So it's quite large. Based upon that, we used a 4x40 serration angioplasty balloon to treat the distal dorsalis pedis, that focal high-grade stenosis, and then used a different 4x120 Serrator angioplasty balloon, both of which were able to be expanded at very, very low pressures. And this is our result. You can see brisk filling through the anterior tibial artery all the way down. It's beating that perineal artery. And then more importantly, we can see that flow all the way down into the foot. We see a beautiful wound blush in that wound distribution area. And everyone can show beautiful angiographic pictures, but I think the most important thing is this, right? We took a wound that was horrific, that I think most patients may have gone on to get a major amputation, most centers around the country. But at 4 months, we had complete wound healing. So that's a great case, not only to demonstrate the utility of Serrator, but it's also a great case to demonstrate the fact that it can be used below the ankle. And no other specialty balloon has been studied below the ankle. So this was a study that was performed that looked at serration angioplasty below the ankle. And we can see that in these patients are the patients with the most severe disease. We saw 97% freedom from major amputation at 5 months. 42% of the patients that were studied went on to improve to Rutherford 0. So that's no disease. And we had an 89% wound healing rate at 5 months. Right? So most patients improved to Rutherford levels. But I think when we're talking about patients with below the ankle disease, we're talking about limb salvage. We're incorporating the consideration that depending on what you look at, 50% of these patients may be dead at 2 years. Now above the ankle, so the bread and butter of my practice is the treatment of below the knee disease, we saw equally promising results in the clinical trial, the Prelude BTK study, right? So they looked at 49 subjects all around the country, all around the world. The majority of these patients had Rutherford 5 disease, so tissue loss, and we saw an impressive 1.9 bailout stent rate. 56% of the patients who had wounds went on to heal them at 6 months, and you were only required to give 6 atmospheres of pressure, which is probably why we saw less recoil, given the fact that there was an average of 21.8% residual stenosis following the intervention. Now, what about recoil? I think what's really exciting is Serrator has been used to examine the implications of recoil, something that hasn't really been done since 2014. So in the study presented by Dr. Lichtenberg at Link 2023, they looked at 40 lesions. Patients were randomized to Serrator versus POBA. And basically what we saw is there was less recoil following serration angioplasty than those who underwent POBA. So the mean recoil across the lesions at 15 minutes was 6% in the Serrator group and 55% in the patients who underwent conventional angioplasty. Now, how many of these patients had a greater than 10% lumen compromise at 15%? I think most people would take like 10% lumen compromise at 15 minutes, but 25% of the patients had a little bit of recoil following serration angioplasty, but 63% of patients had recoil after conventional angioplasty. And of those patients, the ones with the clinically significant recoil were those who had greater than 30% lumen compromise at 15 minutes. Only 10% of the patients who underwent serration angioplasty experienced that, whereas 53% of patients treated with conventional angioplasty experienced residual stenosis. So above the knee, serration angioplasty works really well. This is a case that I did of a popliteal CTO with reconstitution of the mid to distal posterior tibial artery, and utilizing 2 serration angioplasty balloons, a 4x120 and a 3.5x120, I was able to treat this patient expeditiously with an impressive technical result. And this success above the knee has been borne out in the Prelude ATK study, which looked at 25 patients with an average residual stenosis of only 22% following serration angioplasty. But more importantly, when we talk about ATK disease, you want to make sure you have freedom from TLR, and all patients in that study had freedom from TLR. So in summary, serration angioplasty provides a novel solution to the management of peripheral arterial disease. I think it addresses the shortcomings of conventional angioplasty, and it's been studied all over the infrainguinal arterial space. I think it provides predictable results that ultimately will do what we aspire to do for these patients, is to save their limbs. Thank you.